Good morning, doctors. Hope I'm audible. Could you able to hear my voice clear? Good morning. Good morning, doctor. Am I audible? Yes, that's good. Yes, good. Fine. Yeah, it's 6 doctors. I think we can start. Yeah. Shall we start? All right. That's good. Okay, guys. Now for INI-CET physiology, for this next 1 hour, we're going to discuss some key topics that has been asked in the past year INI-CET paper, 2022 November INI-CET, 2022 May INI-CET. Of course, we had questions on certain common topics like spirometry, kind of cells, type of transport. But I'm pretty sure these kinds of topics, spirometry, transport across membranes, or something that everyone would have studied well for INI, for NEET itself. So I don't want to invest time on the topics that you would have been already familiar with. So I have picked the topics that has been quite rare and quite complex and difficult to understand as well as answer. Especially these 6 topics were something students found very difficult in May INI-CET as well as November INI-CET, which is why I'm taking up these topics for our today's discussion, guys. But don't worry, this is a discussion which is planned for 1 hour or 1.5 hours max. So in case you need any more topics to be addressed, you're most welcome to share your doubts or the topics that you need to our company mail, and I'll be happy to address those topics as well. So we'll take up these topics, and guys, as I told you, moments before, these topics are a little bit complex. These topics are a little bit conceptual. So I want you to be very clear, and I want your best attention to be placed upon. All right. So guys, let us take up the very first topic, oxygen hemoglobin dissociation curve, O2 hemoglobin dissociation curve. Guys, at the outset, please be understand, we are seeing a curve which is sigmoid in shape. Oxyhemoglobin dissociation curve is going to be very sigmoid in shape. That's point number 1. Now, you tend to have many pictures on oxyhemoglobin dissociation curve. If you could able to remember your November INI-CET paper, this curve has been asked as a question, and the question was primarily on left shift of the curve. Before even we go on to see the left shift of a curve, in this curve itself, I want you to put your attention to one very important point, because this point is often missed, and diagrams like, diagrams in certain textbooks like Guyton even has got this image less accurate. But in order to answer questions on oxyhemoglobin dissociation curve, you have to have a clear and thorough understanding of this curve, especially about one point, and that is something called as P50. See guys, on our y-axis, we are seeing percentage saturation of hemoglobin. How much of hemoglobin is saturated with oxygen, that is getting represented in y-axis. On the x-axis, you're looking at partial pressure of arterial oxygen. So this curve correlates the relationship between partial pressure of arterial oxygen and percentage of hemoglobin saturated with oxygen. And if you see this relationship at around partial pressure of something called as 26.7, I repeat, this value is quite important. At about a partial pressure of 26.7 millimeters of mercury, you are getting a saturation of 50% of hemoglobin. So 50% of hemoglobin, exactly 50% of hemoglobin in normal health and normal physiology gets saturated at a partial pressure of oxygen, arterial oxygen, PaO2 of 26.7 millimeters of mercury. This relationship is what is called as P50. This relationship is called as P50, that stands for the partial pressure at which 50% of arterial oxygen, 50% of arterial hemoglobin is saturated with oxygen, guys. Remember, if you're looking at a curve, you must have a perfect correlation of 26.7 millimeters of mercury that must stand between 20 and 30. And on the y-axis, it must cut out 50%. So only when you are looking at a curve like this, it means the curve is a normal curve. It's the right curve. So even though you are getting a curve in your question from a different textbook, which has got not a perfect sync with PaO2 and SpO2, that is saturation percentage of arterial hemoglobin, all right, SpO2 on y-axis, PaO2 on x-axis. Make sure you are looking at a correlation that 50% of oxygen, 50% of hemoglobin is saturated with oxygen at a partial pressure of 26.7 millimeters of mercury, guys. And that's point number one. Point number two, you can see the curve. The top part is going to be very flat and the bottom part is going to be very steep. So you're looking at two different parts of the curve. One is a very flat part of the curve and the second one is very steep part of the curve. This flat upper part is telling you that there is going to be very, very little change in affinity. The affinity is extremely static. There is not going to be any much difference in the affinity, even though there is a huge difference in partial pressure of arterial oxygen. Even though the arterial oxygen changes a lot, the flat steep portion, right? The flat steep portion is not showing any much change in affinity. On the contrary, you can clearly see when it comes to the steep part, lower part, this lower steep part, you are seeing a very high release of oxygen. Hemoglobin loses oxygen very quickly, even when there is a little change in partial pressure. With even a trivial change in partial pressure, hemoglobin keeps losing oxygen. So two different stages of the curve. At the flat part of the curve, what you are observing, the affinity of hemoglobin for oxygen is more or less static, right? So even though there is a remarkable change in partial pressure of oxygen, the affinity is not changing much. When it comes to the steep lower half, the hemoglobin affinity is very quickly changed. It's very dynamic. Even though there is a trivial change in partial pressure, hemoglobin loses oxygen very quickly. And these 2 points are quite important when it comes to oxygen hemoglobin dissociation curve and the affinity of hemoglobin for oxygen. Now, why this relationship is non-linear? Why this relationship is sigmoid? And why it is not non-linear, or why it is not straight away like this, right? Why it is not an exponential curve? Why it is a sigmoid shaped curve? This is again a frequently asked question when it comes to oxygen hemoglobin dissociation curve. We call this as positive cooperativity. We call this as positive cooperativity. But the real meaning of positive cooperativity is, guys, there are going to be 4 heme chain, and oxygen is going to be attached with, oxygen is going to be combining with 4 heme chains, all right? 4 heme ring, to be clear. Usually, the affinity of heme for oxygen is very less. Usually, the affinity of heme for oxygen is very less, but when the first heme combines with oxygen, the affinity of second heme for oxygen exponentially increases. So the second heme combines with oxygen much quickly. When two heme moieties have combined with oxygen, the third heme moiety combines with oxygen even with greater affinity. When three heme moieties have combined with oxygen, the fourth heme moiety combines with oxygen with even greater affinity. So if you are looking at the affinity of hemoglobin for oxygen molecule, the affinity is not static, it progressively increases. With every single heme moiety getting combined with oxygen, the subsequent heme moiety do have an increased affinity for oxygen, and that is why at the beginning part of the curve, at the onset of curve, the affinity is very less. So even though you are seeing an increase in partial pressure of oxygen, the affinity is not very much increasing. There is going to be more or less a very less affinity. But once good amount of heme moieties have combined with oxygen, the affinity rapidly increases. And once almost 90 or 95% of hemoglobin is saturated already with oxygen, there is not much hemoglobin available, and hence the curve remains flat. This kind of increasing, a progressive increase in affinity is what is called as positive cooperativity, doctors. So positive cooperativity looks more like a jargon, but in reality, what is happening is there is going to be a progressive increase in affinity. There is going to be a progressive increase in affinity, guys. That is what is called as positive cooperativity. Fine. Now, you are already familiar with 3 points. Number one, the sigmoid shape of the curve. Number two, what happens at the flat top part of the curve? What happens at the steep bottom part of the curve? And number three, why the curve is sigmoid in shape, and what do you mean by positive cooperativity? Now, coming to right shift as well as left shift. Again, this is something you already would have studied, but there is a little amount of points you have to understand here. When it comes to right shift of the curve, what it means is for the same partial pressure of oxygen, the curve is shifted to right. It means the amount of hemoglobin combined with oxygen is very less. All right. Say, for example, if you consider the P50, when the curve is normal, P50 happens at 26.7 millimeters of mercury oxygen. When the curve is shifted to right, when the curve is shifted to right, if you can see at 26 millimeters of mercury PaO2, hardly 10 or 20% of hemoglobin is saturated. It tells us that hemoglobin is losing oxygen. So right shift of curve indicates there is going to be decreased affinity. Right shift of curve indicates there is going to be decreased affinity of hemoglobin for oxygen. Exactly on the contrary, left shift of curve indicates there is going to be increased affinity for oxygen towards hemoglobin. So it's very simple. Left shift, there is going to be an increase in affinity, and right shift, there is going to be decrease in affinity. Have this in mind at the beginning. Now, coming to the conditions that causes right as well as left shift of curve. Right shift of curve is seen in increased partial pressure of carbon dioxide, decreased partial pressure of oxygen, decrease in pH. In another word, it is acidosis, and increase in temperature. Increase in temperature. Along with these three parameters, few parameters you must be familiar with: enzyme, increase in 2,3 diphosphoglycerate. All right. And if you consider the other mechanisms where the curve is getting shifted to right, we are seeing right shift of curve in anemia as well as exercises. In anemia as well as in exercises, the curve is getting shifted to right. So more carbon dioxide, less oxygen, acidotic pH, more temperature, more 2,3 diphosphoglycerate. These are all conditions that shifts the curve to the right, doctors. Coming to left shift of the curve, exactly opposite parameters. Increase in partial pressure of arterial oxygen, decrease in partial pressure of arterial carbon dioxide, and alkalotic pH in alkalotic state. Decreased temperature, decrease to temperature, drop in 2,3 diphosphoglycerate. And the other variant of hemoglobins, guys, this is something quite important. You have to be again familiar with the variants of hemoglobin, but incidentally, it is very easy to understand. Look here, whatever the kind of other hemoglobin you speak about, increase in hemoglobin F, fetal hemoglobin, or myoglobin, carbon monoxide poisoning, where we are going to develop carboxyhemoglobin. These kinds of hemoglobin variants do have left shift of curve. So at one point, in a very simple level, please understand, if your question speaks about any kind of a hemoglobin, definitely the answer is going to be left shift. That is for sure, right? So when it comes to right shift of curve, the hemoglobin variant does not come into the picture. Whenever hemoglobin variant comes into the picture, it is definitely a left shift of the curve doctors. Now, what is most important is you need to be familiar with a little bit of the laws that governs the right as well as left shift and the effects that governs right and left shift. At the outset, let's get to see what is Haldanes effect. Please remember, Haldanes effect is effect of a gas and its partial pressure on oxygen affinity. So whenever there is going to be increase in partial pressure of carbon dioxide, the affinity of hemoglobin towards oxygen decreases. So whenever there is going to be increased partial pressure, I repeat, Haldanes effect is all about gas pressures. Haldanes effect is all about gas pressures. So whenever partial pressure of carbon dioxide is more, just the pressure alone I'm talking about, nothing else, no chemical formulations, no chemical influence, nothing. Simply mere the pressure of a gas itself decreases the affinity of hemoglobin for oxygen. On the contrary, Bohr's effect is something where the influence of acids is manifested on hemoglobin and its affinity towards oxygen. So Bohr's effect is all about acids. Here what happens is whenever there is going to be a decrease in pH doctors, acidic pH, whenever there is going to be acidity, there is going to be a drop in hemoglobin's affinity for oxygen. Ironically, when it comes to carbon dioxide, you have to understand carbon dioxide do influence hemoglobin's affinity by two mechanisms, either by Haldanes effect or by Bohr's effect. In the case of increased carbon dioxide, as partial pressure of carbon dioxide itself, you're going to find a drop in affinity. And what is this effect? It is called as Haldanes effect. On the other hand, the carbon dioxide excess is going to combine with water, and this carbon dioxide combination with water do form carbonic acid, and this carbonic acid split up into hydrogen and bicarbonate. In the presence of more hydrogen, there is going to be a drop in pH, and this drop in pH is going to influence the affinity of hemoglobin towards oxygen, and this condition is Bohr's effect. So guys, remember, the Bohr's effect as well as Haldanes effects are completely different. When it comes to carbon dioxide, that one molecule, we are seeing both effects are getting manifested. So especially when it comes to the gas carbon dioxide, this exerts both Haldanes effect as well as Bohr's effect. That's another point you have to remember. Now, the question exactly asked in November INI-CET, one of a tough question, because the question was, a curve was given, and from the curve, there was another curve that looks completely shifted to the left side, that looks completely shifted to the left like this. And the options given were, is it fetal hemoglobin? Is it myoglobin? Is it carboxyhemoglobin or normal hemoglobin? That was the question, guys. Incidentally, you are going to find three kinds of answers which are compatible for the curve. Because it is a left shift, fetal hemoglobin can be thought of, myoglobin can be thought of, carboxyhemoglobin can be thought of. But which is the perfect answer for the question? For which you need to be familiar when it comes to the different variants of hemoglobin. Let us start with the fetal hemoglobin, guys. When it comes to fetal hemoglobin, you have the picture right in front of you. You can clearly see P50, isn't it? 50% of hemoglobin is saturated at a value of 19 millimeters of mercury, doctors. The P50 value for fetal hemoglobin is going to be 19 millimeters of mercury. And fetal hemoglobin displays a very phenomenal effect called as double Bohr effect and double Haldanes effect. This word double Bohr effect, double Haldanes effect will be asked in neonatal circulation, fetal circulation as well, placental circulation or fetal circulation. Questions on placental and fetal circulation can also be taking up double Bohr effect, double Haldanes effect, guys. What is this? Double Bohr, double Haldane. Again, it's a very simple one. I've given the explanation itself. So please understand, when it comes to Bohr's effect, you guys know it is all about the pH, right? It is all about the pH. So when it comes to maternal blood, there is going to be excessive carbon dioxide in the maternal blood. As a consequence of more carbon dioxide in the maternal blood, this carbon dioxide is going to be converted into carbonic acid. There is going to be drop in pH. When there is a drop in pH in the maternal blood, the oxygen affinity of hemoglobin drops. Thereby, hemoglobin releases more oxygen. It is good for the developing fetus, growing fetus. Number one. Number two, since a fetal metabolism is very, very less, the amount of carbon dioxide in a fetal blood is comparatively very less with maternal blood. Since fetal blood don't have much of carbon dioxide, there is going to be kind of an alkalotic state in fetal blood. You know very well, acidosis decreases the affinity and hence alkalosis should increase the affinity. So obviously in maternal blood, there is a drop in affinity. In fetal blood, there is an increase in affinity. These two factors are brought about by the drop in affinity as well as increase in affinity. Both these factors are brought about by acidic pH in maternal blood, alkalotic pH in fetal blood. And this effect is called as double Bohr effect. Another essential point you have to be familiar when it comes to fetal hemoglobin, oxyhemoglobin dissociation curve. The second one, double Haldanes effect. Double Haldanes effect is again something where we are going to see the effect of partial pressures of gases on the influence of hemoglobin's affinity towards oxygen. What are you seeing here? When it comes to fetal hemoglobin, guys, the more oxygen fetal hemoglobin gets, there is going to be release of carbon dioxide. You know very well, more partial pressure of carbon dioxide decreases the affinity for oxygen. More partial pressure of oxygen decreases the affinity of carbon dioxide. Fetal hemoglobin, again, a quite important point, please remember, hemoglobin, fetal hemoglobin has got alpha 2 and gamma 2, alpha 2 as well as gamma 2. This alpha 2 gamma 2 chain has got a very peculiar characteristic feature. What is that? They have a huge affinity for oxygen. The moment one molecule of oxygen binds with hemoglobin, there is going to be unloading of carbon dioxide. So fetal blood, the moment it starts getting oxygen from maternal blood, there is going to be comparatively enhanced release of carbon dioxide. All right. So the reason for first effect is more partial pressure of arterial oxygen in fetal blood. More partial pressure of arterial oxygen in fetal blood that enhances carbon dioxide release. That is first effect of double Haldanes effect. And the second one, as maternal blood is gaining more carbon dioxide, maternal blood releases more oxygen. Again, it is going to be a beneficial effect for the growing fetus. All right, people, as maternal blood receives more carbon dioxide, there is going to be release of oxygen. So that is double Haldanes effect and double Bohr's effect, guys. All right. So two very important parameters you have to be familiar with. Please remember, double Haldanes effect, double Bohr's effect has been asked in the past decade. 2010 to 2020 question papers had this question. AIMS question paper, PGH Chandigarh question paper had this effect, double Haldanes and double Bohr's. From 2021 to 2020, from 2011 to 2020 onwards, in the past decade, we have not got any question on these two topics yet. But when it comes to oxygen hemoglobin dissociation curve, every time or every few years, AIMS or NEET board, DNB have got a priority that they are asking different questions on the same topic. The topic is getting very frequently repeated, but incidentally, the questions are very, very, very different. All right. The best example is last year's question. We had not had any question on myoglobin, fetal hemoglobin curve so far yet. All right. But on November, INI-CET paper had that question. So please remember, you have to be clear and thorough with every single aspect of oxyhemoglobin dissociation curve, in which these two topics, double Bohr effect and double Haldane effect, is something that has been asked very long, and there is a good chance that this might get repeated. Be aware of it. And what you're seeing here is a curve that stands for fetal hemoglobin, even though it is a left shift, even though it is a left shifted curve, it's not going to be wildly shifted. The P50 value is going to be 19 millimeters of mercury. I want you to put your focus on that one parameter. All right, guys. So your choice of option is going to be based on the P50 value for different kinds of hemoglobin, even though they all shift the curve towards left. And since the hemoglobin F has got gamma chains, the affinity of 2,3 BPG is going to be very, very, very less. The reason is 2,3 diphosphoglycerate binds with beta chains. It binds with beta chain, and beta chain is seen in hemoglobin A, whereas hemoglobin F, fetal hemoglobin, do not have beta chain. On the contrary, they have gamma chains. As a consequence, the affinity of 2,3 diphosphoglycerate for fetal hemoglobin is going to be very, very, very less, doctors. Remember that. Which is why we have a curve which is getting shifted to left. Because there is less 2,3 diphosphoglycerate, the affinity is going to be increased. We discussed that again. Right, less 2,3 diphosphoglycerate, and the curve is getting shifted to left. Coming to myoglobin and carboxyhemoglobin. Myoglobin has got only one heme moiety. You know very well, when it comes to hemoglobin A, adult hemoglobin, there are 4 heme moieties. There are 4 heme, and there are going to be 4 globin chains, 2 alpha, 2 beta. When it comes to myoglobin, there is just one heme moiety, and there is just going to be one globin chain. Because there is going to be one heme and one globin, even though there is just one heme, there is going to be enormously very high affinity for oxygen. Very, very, very high affinity towards oxygen. As a consequence, even though one oxygen is going to combine with heme of myoglobin, there is going to be a significant affinity, and as a consequence, you can clearly see the curve. The curve is practically touching the y-axis. The curve is practically touching the y-axis, people. So here, 50% of hemoglobin is saturated hardly at 5 or 6 millimeters of mercury oxygen. So when it comes to P50 values, it is close to be around simply 5 millimeters of mercury partial pressure of arterial oxygen. So again, if the partial pressure of arterial oxygen is 19 millimeters of mercury, where you are seeing P50, the answer for the question is fetal hemoglobin. If it is myoglobin, the partial pressure of oxygen is going to be 5 or even less than 5 millimeters of mercury, where you're going to find 50% of hemoglobin saturated with oxygen. When it comes to carboxyhemoglobin, a very interesting compound, you're going to find this in carbon monoxide poisoning, the cherry red poisoning. When it comes to carbon monoxide poisoning, what happens is, guys, it's very interesting. See, we were talking about 4 heme moiety, and these 4 heme moiety is going to be attached with 4 globin chain, 2 alpha globin chain, and let's take up 2 beta globin chain, guys. 2 alpha, 2 beta. And you know very well, when it comes to the affinity of oxygen, the first oxygen combines with heme with less affinity. The second oxygen combines with heme in a slightly increased affinity. The third oxygen combines with heme in a much greater affinity. The fourth oxygen combines with heme in a significantly high affinity. So there is going to be a progressive increase in affinity for hemoglobin towards oxygen. When it comes to carbon monoxide, remember this one point: carbon monoxide competes with oxygen for exactly the very same binding site. For exactly the same binding site on ferrous ion, carbon monoxide competes with oxygen. So what's going to happen? Since carbon monoxide competes with oxygen, you can clearly see the first oxygen molecule is loosely combined with hemoglobin. The second oxygen molecule is again loosely combined with hemoglobin, whereas the third oxygen and the fourth oxygen is combining with hemoglobin with a very strong affinity. Now, what happens? Which oxygen is easy to get displaced? Obviously, the first oxygen. So what carbon monoxide does? Carbon monoxide replaces oxygen and it binds with ferrous atom at the exact same spot. Again, the second oxygen is easy to get displaced. Carbon monoxide replaces the second oxygen and combines with ferrous at exact same spot. As a consequence, what happens to the affinity of hemoglobin for the third and fourth chain, for the third and fourth oxygen molecule? The third heme moiety and fourth heme moiety do have the same high affinity because the exact spot where oxygen is going to combine with ferrous is occupied by carbon monoxide. Since that spot is filled and occupied, the hemoglobin is not going to change chemically. As a consequence, there is going to be a fixed, rigid structure of hemoglobin. So the third oxygen and fourth oxygen cannot be taken away from hemoglobin at all. So what happens? Out of 100% of oxygen, 100% of hemoglobin, 50% of hemoglobin is saturated with carbon monoxide, other 50% of hemoglobin is saturated with oxygen. So the last 50% of hemoglobin is taken away by carbon monoxide and only 50% of hemoglobin is saturated by oxygen. So what happens to oxygen hemoglobin dissociation curve? It's going to be shifted to left because the affinity of the last two chains for oxygen is increased. Please remember, you are looking at the oxygen hemoglobin dissociation curve in carbon monoxide poisoning. You are not looking at a carbon monoxide hemoglobin dissociation curve. You are looking at a oxygen hemoglobin dissociation curve, doctors. Please remember. So at carbon monoxide poisoning, only 50% of hemoglobin is saturated with oxygen. And even in that case, the 50% of hemoglobin, if you see, has got very high increased affinity. That is all. All right, people. So I just want you to have a completely clear understanding. This is a very tough question asked in INI-CET November 2022, people. So be very clear with the shape of the curve, the reason behind the left shift and everything. So guys, before even I move on to the next question, do you have anything confusing or any doubts in oxyhemoglobin dissociation curve and the mechanism behind it, people? Guys, please do share if there is any doubts in these basics. This is the most important point. I want you to be very clear with. Fine. Good. So guys, we'll move on to the next topic, ocular cephalic reflex and ocular vestibular reflex. These two reflexes are something that we have not conventionally given importance to, but this is a question asked in May INI-CET 2022. For the first time, we are getting a question on OC reflex as well as OV reflex. The question especially is on ocular cephalic reflex, doctors. This is the question that they have asked. But incidentally, you also need to be familiar with ocular vestibular reflex because once ocular cephalic has been asked, there are a good chance that ocular vestibular can come into the picture. Why are we doing these two tests? Both these reflexes are done to evaluate the intactness of brainstem. Please remember, we are not at all evaluating cerebral cortex. We are not evaluating cognitive functions. We are not evaluating motor cortex or sensory cortex or limbic cortex or thalamus or hypothalamus, absolutely nothing. The oculocephalic reflex, oculovestibular reflex are used only to evaluate brainstem intactness. Doctors, let me give you, a hint of point here. I just want your attention here, guys. All right. Once the discussion is over, I'll share the PDF with the company, and ADrPLEXUS will be sharing the PDF with you as well. So don't worry about writing things down. I just want your attention. You are going to have this PDF with you no matter what. So what is oculocephalic reflex? What we need to do is, we got to, make the patient to lie on a couch. We got to hold the patient's head. We got to ensure the patient's eyes are open. Oculocephalic reflex, patient's eye must be opened up. Right? Yeah. Sorry for the inconvenience. It's a power failure here, guys. The patient's eyes should be open. And we have to hold the patient's head. And we are going to tilt the patient head towards left. Hold it for some time. Tilt the head towards right. Hold it for some time. What is the response you're going to observe? When you hold the patient's head, when you tilt the patient head towards left, the eyeball should move towards right. When the head is turning left, eyeball should be moving towards the opposite side, right side. When you turn the patient's head towards right, the eyeball should move towards left. So there must be a contralateral movement of eyeball to the direction of movement of head. Got it? So if the head is briskly turned from side to side, the head held briefly, you can't be quickly shifting. Once you shift the head to one side, hold it for some time and then bring it to the neutral position. So when you do that way, you are going to get a positive response where you're going to see the eyes rotating to the opposite side of the direction of head rotation. And this gives you an idea of intact brainstem functions. What are the cranial nerves that is going to support this possible movement, guys? Now, you turn the head of your patient to one side, the eyeball is moving to the other side, right? So this is practically lateral movement of eyeballs, right? So by this way, you are testing oculomotor nerve, you are testing trochlear nerve, also you are testing vestibulocochlear nerve, because the whole reflex is elicited from semicircular canals. Lateral semicircular canals gives the inputs to the brainstem, especially the region where oculomotor nerve nucleus is present, trochlear nerve nucleus is present, midbrain in particular, and the reflex is getting mediated. So the nerves which are involved in oculocephalic reflex is oculomotor nerve, trochlear nerve, as well as vestibulocochlear nerve. People, you are testing cranial nerve 3, 4, and 8. A similar kind of reflex is seen when the patient's head is fixed and flexed as well as extended. In the exact same way, when you flex your patient's head, eyeball should move up. When you extend your patient's head, eyeball should move down. So again, you're going to have a opposite movement of eyeball to the side of patient's head movement. You are testing cranial nerve 3, cranial nerve 6, as well as cranial nerve 8. Cranial nerve 3, 6, and 8, doctors. All right. So you are going to test the movements of head along with the eyeball movements, people. And again, you're also going to evaluate cranial nerve 4 as well in this circumstances also. Cranial nerve 4 is getting involved here. All right, guys. So in the presence of cranial nerve 4, the muscle that we are going to test is going to be lateral rectus. This muscle is going to be superior oblique. Superior oblique, which is going to bring the eyeball down. And this is exactly what is called as doll's eye phenomena. This response is what is called as doll's eye phenomena. This is doll's eye phenomena, doctors. All right. So that is the oculocephalic reflex, people. And please remember, when you shift a patient's head to one side or other side, as I was telling you, you got to hold the head for some time. The moment the eyeball comes to the opposite direction, the eyeball gradually, very smoothly come to the neutral position. And that is also you have to check and evaluate. This is not just the movement of eyeball alone. This is very important. Please ensure that this is also a returning of eyeball back to the original position, guys. That is oculocephalic reflex. Now coming to oculovestibular reflex. Oculovestibular reflex is also called as caloric stimulation. It is also called as caloric stimulation. What you are going to do is you're going to add ice cold water into ear. All right, you're going to add ice cold water. So the head is elevated to 30 degrees above the horizontal line. From the supine position, the head has to be elevated to 30 degrees, and you're going to introduce iced water into the external canal through a very small catheter until you're going to see nystagmus. Very, very, very important. Until you're going to see nystagmus. All right, and please remember, if the nystagmus is present in the intact brainstem, the slow phase is always towards the irrigated ear. The slow phase is always towards the irrigated ear, doctors. And if you're not seeing a nystagmus, if there is a lesion, at least you have to look for eyeball deviation. You got to look for eyeball deviation, doctors, and this is oculovestibular reflex, and the normal response is going to be nystagmus. Normal response is going to be nystagmus, doctors. All right, this is oculovestibular reflex. Fine. Moving on to the third topic, interpretation of iron studies. Again, it's a question that has been asked in May INI-CET 2022. The question was essentially focusing on ferritin. Why are we giving so much of importance to iron studies, and why suddenly this importance? Of late, there is going to be more cases of coming up with anemia of chronic illnesses, and the definition has been a little bit changed. All right, it is no more anemia of chronic diseases. It is being named as anemia of inflammation, AI. All right, people, anemia of chronic disease is renamed as anemia of inflammation. And these conditions, anemia of chronic disease as well as anemia of inflammations, these conditions are manifested with microcytic hypochromic anemia. And when it comes to microcytic hypochromic anemia, the other very common differential diagnosis for microcytic hypochromic anemia is going to be iron deficiency. So frequently we are getting questions where we have to discriminate between iron deficiency anemia and anemia of inflammation, which is why we have to be very familiar about the markers for iron deficiency and how iron studies gets altered when there is going to be anemia of inflammation or iron deficiency anemia. Let us take up ferritin. Please remember, ferritin is going to be the gold standard marker for assessing iron stores. Ferritin is practically seen in all cells, but especially ferritin is very, very, very abundant in hepatocytes. Ferritin is very abundant in hepatocytes as well as reticuloendothelial cells. And please remember, a small amount of ferritin is always present in mucosa. In all the mucosal linings, all right, oral cavity mucosal lining, GI mucosal lining, we are going to see ferritin. So please remember, ferritin is not just an intracellular protein alone. It is also a mucosal protein, and the importance of ferritin in the mucosa is we need this ferritin in the mucosa to trap iron. Only when mucosal ferritin traps iron, microbes, microbial organisms that sits over the mucosa will not able to utilize the iron, and iron can be used for our purposes. So that's the reason where we have mucosal ferritin deposition, guys. And ferritin is synthesized by liver, all right? It is going to be a hepatic synthesis. Hepatic synthesis. And when liver triggers the synthesis of ferritin abundantly, whenever there is going to be more iron, in order to buffer these iron and in order to store the iron, liver starts synthesizing ferritin. All right. So in what condition you are going to see very, very, very less ferritin? You have just understood this. The ferritin synthesis is